these days, and the topic today is new treatment paradigms for negative symptoms and cognitive symptoms, the myth of treatment resistance. To throw light on this, we all have the one and only Bhaskar Mukherjee. He doesn't need any introduction. My request to all the people attending is please mute your mics so that you don't cause any disturbance. And if you have any questions, you can put it in the chat box, or later on, once he finishes his presentation, we can unmute and raise up your hands and you will be given the permission to talk. Thank you very much. Dada, the floor is yours.
Okay. Today would be a bit anticlimactic because people are expecting that I would give them detailed guideline of use this medicine there, use that medicine there. That is never going to happen because by now, I have started this 8 series session with the main plan to make you understand that there is no single disease known as psychosis. There is no single disease known as mania. There is no single disease as schizophrenia. There is no single disease as bipolar. It is a conglomerate and it has millions and millions of pathways. And through these pathways, each person's dysfunction is finally exhibited in form of disturbed behavior, disturbed thought process, or disturbed cognition, or disturbed motor process. So standing there is never going to be a single pill curing all. So that is why I myself am taking this series. Once this series ends, it would be everyone speaking. Malay Bhai would speak some, other people would speak some. We have created a group of almost 100 speakers by now, and they would come and talk about different brain topics. I just needed these 8 sessions to clarify the concept that brain is a organ that is widely misunderstood. People think that for everything, just there is a magic pill, give the pill, patient would get all right. And we are a failure if we can't provide the magic pill. But there would never be a magic pill. There would be a group of drugs. Treatment of brain is polypharmacy. And it would always stay as polypharmacy. Nobody treats liver alone. There is not a single magic bullet for liver, not a single magic bullet for heart, not a single magic bullet for GI system, not a single magic bullet for kidney. So why should the brain, the master organ of all these, have a magic bullet? This magic bullet concept needed dispelling. So I have taken the pain of organizing these 8 series of lectures. Today would be penultimate lecture, and next day we would follow up with case series where we would show how we can treat patients differently with live cases. So with this, let's start today's presentation. I would give you lots and lots of options, but I am not going to give you a magic bullet. So, molecular psychopharmacology from basic to bench side. This would be the actually penultimate talk of this series. There is a series planned on depression and addiction, but may or may not happen by me. I want someone else to take the charge of those. So, how to treat negative cognitive and neuroprogression symptoms scientifically and pharmacologically. And treatment really starts after hallucinations are over. This you always have to understand. Hallucinations are most important symptom for most psychiatrists. Once there is patient has no hallucination, most psychiatric thinks that the job is over. Now I can relax. We cannot relax. Hallucination is the most severe dysfunctional form that affects the family. But for patients, hallucinations are not the most dysfunctional thing. The dysfunctional things have started from for the patients in utero and would go on till their life is there. So we have to think from their perspective. So discussion so far, what we have discussed. Cellular hype. If you remember the last talk, I have given you some understanding about cellular hyperexcitability, how that happens. I have also talked about intrinsically disordered protein response. I have also talked about a lot of things in various areas that can produce cellular hyperexcitability. And then I give the second component, neuronal migration disorder, whether a group of neuron or a large part of neuron or just one or two neurons which has failed to reach its area. They ultimately gives us positive symptom, negative symptom, manic symptom, aggressive and impulsive symptom, mood symptom, and neuroprogression. It is their various combination that can give us various phenotypical forms, as I discussed before. And this phenotypical form ultimately has to be managed through targeting these two only, this and this. Our problem is this because this cannot be managed. Why? We would go that later. So, this is how these two vulnerabilities progress. First, there is inherited genetic vulnerability, that is parental inheritance plus genetic recombination inheritance. Both parents supply 25% of their gene unchanged and 20% of their gene as recombinant gene. This recombination gene is the uniqueness of us. So from both side of the parents, we get 25% recombinant gene, total 50%. This 50% recombinant gene would decide how much we differ from our parents and how much we don't. Now, after that, the second layer of vulnerability is somatic mutations affecting all body cell. That is somatic mutation that develop after first 16 cell lengths. But then somatic mutation can only affect the total brain only. Then somatic mutation can affect only specific areas of brain. Ultimately, we would get some mutation in hippocampus, some mutation in amygdala, some mutation in the neurons residing in cerebellum, and that would be unique to those areas. Other areas, those mutation won't happen. Then there would be a group of mutation that would affect all brain cells. Now, the group of mutation which affects all brain cells can be divided into two. One is brain specific genetic mutation, one is brain and body combined genetic mutation. Now, brain and body combined genetic mutation can be of two forms. Number one, that is germ cell division associated mutation, and number two is somatic mutation. Now, there is the epigenetic vulnerability that would get added to genetic vulnerability. That can be body specific and body system specific vulnerability. That can be brain specific epigenetic vulnerability. And then the final layer of problem is done by maternal fetal interaction, and this triggers the final changes. So we have to understand all these things are happening in utero, and in utero it has to be addressed. This is a small idea of maternal fetal interaction, as I didn't talk about it last time. This is baby, this is placenta, and this is various areas of placenta. We psychiatrists has to know placenta very well because we are the ones that ultimately work through our drugs in placental area. What has happened? Yes. I wanted to mute my video. Just a minute. Yes, my video is muted. So this is a section of placenta and its different component. This is fetal blood circulation, and this is maternal blood circulation, maternal myometrium. These are various components: extravirus trophoblast, MAIT cell, which is a kind of specific T cell which accumulates in the maternal blood and is actually mucosal associated T cell. Then there are various extracellular components, and through it, maternal condition influence fetal condition, and fetal condition influence maternal condition. This is a slight different way of look at it, and DOHA is actually perinatology's name of developmental origin of health and diseases. This DOHA, this full form is developmental origin of health and diseases. And this whole picture is a schematic how we should investigate it and learn it. Not by talking about feto-maternal diet, not by talking about perinatal psychology, not by doing things that has no meaning and only satisfies our ego. This is something that should be followed up and would be finally screened to find out how various fetal and maternal interaction changes the brain development, brain utilization of fetus, as well as what fetus is doing to maternal brain. Unfortunately, in psychiatry, nobody is doing it. And that is what needs to be done to understand how to treat psychosis and mania properly, because it is all happening here and here. These areas where we have no access. This is a slight chart showing only NFKB pathways in normal and pathological pregnancy. During implantation, NFKB rises. During maintenance, maternal fetal interface, NFKB falls, and various other things changes. In normal term labor, various things change along with NFKB rise. In pathological pregnancy outcomes, specifically spontaneous abortion, decrease pro-inflammatory cytokine and increase T helper 1, which is actually repair cytokine. In preterm labor, early activation of NFKB pathway and pro-inflammatory mediators activate. In IUGR, there is always inflammatory activation because the baby is not getting much growth. So inflammatory pathways are trying their best to increase the growth of baby. So how are we going to treat it if it's all starting in utero? If it is all starting even before pregnancy, how we are going to treat it? Because remember, the ovum has already formed, which is 25% recombinant DNA and 25% maternal old DNA. The sperm has already formed, 25% recombinant DNA, 25% own DNA, and we can never expect to change it at this moment until and unless we start treatment at the beginning. Maternal and paternal treatment, adequate treatment of their conditions. Adequate treatment of their conditions, including all non-communicable disease condition, adequate treatment of brain, forgetting that psychology says this or philosophy says this or any other humanity says this, because until and unless we treat the mother and we treat the father, we can never ensure the adequate condition of their end of contribution. Then maternal pregnancy. Forget fetal maternal diet. I suggest any perinatology enthusiast who is listening to the lecture, forget and throw that diet concept into the dustbin. There is no diet, there is a single unit, fetal maternal unit, and that is more intricately joined than your psychology can ever tell you. So never deprive mother of any treatment. No psychotropic can harm mother enough to justify its non-use. No psychotropic. Valproate is the only one, and even valproate at this moment, if cannot be replaced, has to be continued, because without treatment, if a mother goes to pregnancy, that is the biggest curse that you can place upon a baby. There is no question of your psychobabble, there is no question of your uh, therapy would cut the cheese. If you are not confident enough to use drug, send to your colleague who is going to use it, but don't destroy the future of the baby. Treatment we cannot do in intrauterine phase. That is the problem. In intrauterine phase, we don't know what is happening. We don't have any idea what changes fetus is going to, because intrauterine treatment is going through a lot of obstacles from religious point of view, psychological point of view, philosophical point of view, and unnecessary ethical issues. Yes, unnecessary ethical, because ultimately we are dealing with human lives. If we don't know what happens inside a human fetus when the mother is having serious brain disorders, we can never treat the condition. No amount of machine learning, no amount of model building, no amount of anything can replace the real fetal changes. So we should do biopsy of every fetuses. We should do biopsy of every abortions, because ultimately that is what is going to give us some understanding. So at this moment, intrauterine treatment is not possible for us except continuing the psychotropic the mother is on. That is the only intrauterine treatment we can offer the baby, nothing more. Then the last treatment principle is anything that has eccentricity and deficit in neuromigration has to be treated lifelong. These two conditions would never go away. So there is no question of we would give treatment, then we would have observe a drug holiday. You are not medical psychologists. We are doctors. We have taken an oath to save lives. We cannot give this kind of foolish advice of stopping drugs. Deprescribing patients of psychotropic is the biggest mistake that we can do. Now comes the treatment modalities for which you are waiting. There are treatment modalities beyond pharmacotherapy, but at this moment of time, I am focusing on pharmacotherapy because electrical stimulation or anything that we can give to a patient, let's say pep up talk, let's say cognitive exercises, let's say ketamine or other psychedelic, they are temporary. Until and unless we can give them lifelong regularly, they are going to be temporary. And at this moment, there is no lifelong TDCH or RTMS or deep TMS portable thing that we can order the patient to wear. So pharmacotherapy consists of two drugs. One is the drugs that is traditionally psychotropic and the drugs that are not traditionally psychotropic. And I have kept antidepressants first. Why I have not given anything under antidepressant? Because if I expand this, we would sit here till next 7 days. So I would talk about antidepressant in a nutshell and in very specific way. Antidepressants doesn't exist. These are drugs which are misnomer. They are drugs which increases brain's functional capability, brain's capacity to adjust to various environmental factors, be it internal environment, be it external environment, and these are drugs which increases so-called neuroplasticity. So, in treatment of any negative cognitive and neuroprogression, antidepressants come first. What antidepressants can be given? Anything that the patient tolerates. What gives us some ideas about which drug a patient can or cannot tolerate? Depends upon initial activation symptom. If a patient is showing activation symptom with an antidepressant, it is better not to continue the antidepressant because activation symptom means the antidepressant is going to excite the autonomic nervous system, and that is going to cause a lot of problem in brain and body, and frequently that would be unpleasant to bear, and many a time that excitement can go to a high extent, and that ultimately can label a patient schizoaffective for life because His Highness Henry Akiskal has made bipolar 1 to bipolar infinity classification. And it is very easy to stamp a patient, but it is almost impossible to remove the stamp. And with that stamp, the treatment becomes very hard because no psychiatrist is ready to give full dose antidepressant to a patient who has a stamp of bipolar. So better avoid those drugs which are stamped as activating in a patient. Now, activating doesn't mean the usual stamp. Activating means to which the patient is finding difficulty of falling asleep, difficulty of increasing appetite or difficulty of decreasing appetite, along with the patient is feeling palpitation and restlessness. This is activation. Many a, many a times, actually, escitalopram can be activating. Many a time, fluoxetine can even not be activating. Depends on peculiar patient's response, and that can only uh, be predicted very, very grossly. Antipsychotic. Antipsychotic is the basal drug which causes reduction in basic neuronal activation tone. In presence of antipsychotics, every neuronal excitation activity goes down. If it goes down too much, then there is chance of paradoxical activation or disinhibition, and we would term it seizure, which is unfortunately silent channelopathy or silent other excitatory disturbance that's been triggered by too much slowing down. But otherwise, antipsychotics are drug that reduces neuronal excitability. So standing there, all antipsychotic could do, the so-called second generation has associated low-grade so-called antidepressant activity. So many a time they are preferred, but in case of severe excitation disturbances, the so-called first generation or the drug which have more inhibitory activity are still preferred. Antiepileptic. Antiepileptic means all the medications that reduces neuronal transmission, that reduces neuron to other body cell transmission, and that reduces muscular excitation and neuromuscular excitation. So anti-epileptic by their very definition would reduce the brain activity, muscular activity, neuromuscular activity, and would stop the excited oxygenity. That is good because that would give the patient some respite from cognitive deterioration, some respite from continue progressive neuronal damage, and would give some respite from neuroprogression. But they again come with their own baggages. A certain degree of brain transmission and neuromuscular activity is required to carry out daily work, to carry out normal cognitive work, and to carry out various other work that is needed for daily living. Anti-epileptic, if given in high dose, would cause the same problem of anti-psychotic and make the person slow, make the cognitive activity slow, and ultimately would be producing more morbidity than it is needed. Stimulants. Now we are coming to interesting areas. There are two kind of cognitive symptom in patients with psychosis. One is disease produced cognitive deterioration. Another one is produced by anti-epileptic and antipsychotic. The second one is glorifiedly called antipsychotic induced deficit symptom. I would also say this would name anti-epileptic induced deficit symptom. Not really a good name because where drug induced deficit symptom end and where disease induced deficit symptoms start, nobody knows. There is no way we can demarcate that. Only way is reducing drugs and many time reducing antipsychotic still give us some improvement, but reducing anti-epileptic beyond a certain dose won't give us much cognitive improvement. So standing there, stimulants comes to play as very early cognition enhancer. Now by stimulant, what I am saying, because by now my definition is differing from standard textbook. So stimulant means any drug which increases attention, concentration, and ability to do one thing repeatedly. The first kind of stimulants is antidepressants themselves. Now, all the drug which has an antidepressant tag would be stimulant of most harmless kind. Then comes the traditional stimulants. Means these drugs are mostly used in attention deficit or rather attention deficit trait. The first drug is bupropion, and the second closest drug is modafinil. Personally, with reasonable scientific logic, I always recommend modafinil first, bupropion second. Why? Because modafinil has an advantage of very short time action, very short duration of action. So, if the patient has severe hyperexcitability trait with this type of drug, then modafinil can get out of the system quickly, and we have to deal with short-term destabilization. In bupropion, the action is slow, and so in bupropion, once the action builds up, it is difficult to stop the destabilization. So bupropion would give a medium level destabilization. So if we are trying to use stimulants, the best idea is to give a trial of modafinil. If patient is tolerating that, then instead of modafinil, bupropion should be tried, because bupropion has more alertness promoting property than modafinil. Then comes atomoxetine. Atomoxetine, if someone is giving, that dose should be very little and should be increased very slowly, because atomoxetine is longer acting than bupropion, and its action builds up quite slow. But once its action builds up, it takes quite a while to get out of that action. The half-life formula doesn't apply to most of the drug, and similarly in atomoxetine 2, it doesn't really apply. Once a patient gets sufficiently activated by atomoxetine, it takes 2 to 3 months for the basal autonomic tone to return to normal. So standing there, atomoxetine, if it works, is a very good drug, but if it doesn't work, we should be prepared for 2 to 3 months mild or moderate to major destabilization. Then comes methylphenidate. Like modafinil, methylphenidate has an advantage. Its action is short lasting. Neither it builds up like bupropion or atomoxetine, neither it stays for weeks and months. So we can try methylphenidate, but the dose has to be very low. Ideal dose to start is 2.5 mg, followed by gradual increment of 2.5 mg every 10 days. In India, we have made the patient habituated to improvement by 2 days or 3 days. And both patient and we get impatient if there is no improvement in 10 days. But while treating our deficit patients of psychosis, be it negative symptom, be it cognitive symptom, be it neuroprogression symptom, we have to be very, very patient, because whatever we are giving, we are actually slowly and gradually trying to change the basal brain function. That needs time and that needs finesse rather than crude activity. So I would suggest never give the family and patient a timeline that I would make the patient well in 10 days. Other doctors I don't know what I can do. Do not say this to these patients. This is not a very wise decision in these patients. Go slow. Every trial should be slow. Every trial should have a very low build up. Go to higher dose, but slowly, gradually. Now comes the long-term drugs, NMDA modulator. I have not given the name NMDA antagonists because none of these drugs are true antagonists. They are low potency partial agonists and they are mostly retaining some kind of agonistic activity. Why? Because let's face it clearly, Stahl, for all his pictures and Bob Dylan dance and his marketing, is someone who has never seen patients. So he has never noticed that if we think clearly, neuronal disconnection, neuronal migration problem means at any given area, the number of neurons is less. So the number of active synapses is less. So there can never be higher glutamate level in brain. Rather, it is different. The excitatory synapses, the glutaminergic synapses that are there, they are overworked. They cannot manage things properly, and they have a high receptor turnover, and they need actually glutaminergic drug to work well rather than blocking glutaminergic receptors. So, if we think scientifically, memantine can only work if it is enhancing glutaminergic connection. Memantine can only work if it is enhancing the excitatory transmitter of brain. And if there is anything that can measure glutamate levels in different areas of brain in psychosis, that study is bound to find low glutamate level rather than high glutamate level. Glutamate hypothesis of Stahl, him being non-scientific, non-clinician, is very, very faulty. And in psychosis, brain has less glutamate rather than more glutamate. So NMDA receptor modulator are drugs which either partially or fully increase NMDA receptor function. Partially would be better because we don't know the full activation and what it is going to do. So all we have is dextromethorphan and memantine as partial agonists. They are low level partial agonists, but they are partial agonists. They are not blockers. They have intrinsic activity at receptor. The more we know, more we would find out. Cholinergic drugs and their combination with NMDA receptor modulators. NMDA receptor is an intrinsically disturbed protein and it has an intrinsically disordered tail. That tail has many functions, but one of their function is interrupting or enhancing cholinergic activity. So, if we give cholinergic agonist with various NMDA receptor modulators, there is a chance that there will be greater activity than both of the drug given alone. Now, cholinergic drugs, specifically galantamine, specifically galantamine at higher dose, has evidence and efficacy in some of the cognitive symptoms of chronic psychosis. But we have to choose these patients carefully because cholinergic drugs are also activating drugs. So these should be patients who have more deficit symptom rather than more aggressive symptom or more high excitotoxicity symptoms. Unfortunately, we are Neanderthals and Cro-Magnons trying to decipher a quantum computer with our Neolithic or Paleolithic equipment. Cholinergic drug, memantine, all of them are Paleolithic equipment. We should get some drugs which are specific enough to do this and that, nothing more than that. Our Paleolithic equipment and Neolithic equipment has its place because none of the diseases of brain is limited to brain. They are whole body disease. So our tools can access whole body. The specific thing, the specific monoclonal antibody cocktail that we can get in future would not be able to do whole body thing, but they would have a idea of using just the specific work at the specific area of brain. Anyway, so cholinergic drugs have their role. Then orexinergic. Already one group of drug I have talked about is morphine. Now, orexinergic drugs are also DORA. DORA group can reduce the aggression symptom, can reduce the excitotoxicity, and can reduce the impulsive symptom. But there has to be a trade-off because too much DORA activity would lead to cognitive dulling and cognitive dumping, same as antipsychotic, same as anti-epileptic. Because DORA group of drug are antipsychotic as well as anti-epileptic combinations. Next come opioidergic. We don't use opioidergic drugs in psychosis. But if we think and if we understand, opioidergic drug would work us, we would give us a beautiful alternative to various treatment modalities in case of enhancement of executive cortex function because the executive circuits of brain is rich in mu opioid receptors and rich in few other opioid receptors like zeta opioid receptor. Also, the other areas of brain which inhibit prefrontal cortex or executive cortex, they have a preponderance of kappa opioid receptor and OPRM receptor. So, standing there, if we use kappa antagonist or if we use mu agonist in psychosis, specifically the chronic psychosis, the psychosis with cognitive dulling, then there is a chance that we can get various mood effects, we can get various cognitive effect, as well as we can make the patients better without destabilizing other areas. The problem is all the mu agonists are now banned due to America's works over America's war on drugs, and we have kappa antagonists in form of our naltrexone. But the problem is naltrexone needs to be added to something more powerful. Only naltrexone many a time doesn't give us much improvement in cognition in these patients. So what can be added? There is a beautiful combination there. It has actually gotten very much advertisement in media. Samidorphan and buprenorphine combination that would work as very interesting way in this field. But as I don't have it in my disposal and I cannot give it at this moment, so I don't know how this scientific understanding would translate into real clinical practice. But always remember, if we get that combination in India someday, we have to try it in cognitive symptoms of chronic psychosis, chronic mania, and any chronic cognitive deficit state of serious mental disorder. I hate saying serious mental disorder, but my subject has not still abandoned mind. Now, cannabinoid drug, a drug which is very, very controversial because most of the psychiatrists are dead sure that cannabis causes psychosis. We don't really know whether it causes psychosis or not. So far, we have association, but we also have alcohol associated hallucinations. We have opioid hallucinations. So, why we are prosecuting cannabinoids as a group, that I don't know. Everything that can be said as hallucinogenic or can be said as psychedelic has to have an association with psychosis because these are the drugs that those brain crave. These are the drugs that can elevate their constant low mood. So whether it is the chicken or egg, that I don't know. But still, respecting opinions of other psychiatrists, I would not say about THC, but I would definitely say about CBD, cannabidiol. Cannabidiol being a very good anti-epileptic has its effect on aggressive symptoms, as is its effect on sleep, has its effect on impulsive symptom. Cognition enhancement is a job of THC, and I am not going there. But in other areas, cannabidiol has a good role. Then psychedelics. LSD, ketamine, nitrous oxide, then come ecstasy. Their use is holy grail in psychotherapy, but they can also be used to combat the anhedonia of chronic psychosis, the anhedonia of serious mental disorder, and, and they can definitely be a part of our daily treatment of cognition remediation in psychosis once they get sufficient approval, because all of them has their own cognitive effects. Then dopaminergic drugs, the most dangerous ones, because we can exacerbate psychosis definitely by these drugs. So why talk about this drug? In very resistant cognitive deficit, in completely withdrawn cognitive deficit, in cognitive deficit where nothing seems to work, very low dose of dopaminergic drugs work. The lowest possible drugs are always better. The indirectly acting drugs are always better. Means the drugs which are suitable are amantadine, safinamide, COMT inhibitors, that is entacapans, but they definitely not levodopa. And they have a beautiful area of use in addition to cognitive symptoms, the motor symptom, the chronic motor symptom, the tardive dyskinesia, tardive dystonia, the various forms of tardive disorder, they respond beautifully to amantadine, safinamide, these type of drugs. But please do not try levodopa in this. So this is traditional pharmacotherapy that we psychiatrists know of, but most don't practice this much variable. Now comes the drugs that's traditionally non-psychotropic. Kinase inhibitor. Kinase inhibitor is a large group. Tamoxifen and endoxifen is the only thing that we use, but Janus kinase inhibitor and various other kinase inhibitors used in various forms of rheumatological disease can also jolly well control aggressive symptom, psychotic symptom, means so-called positive symptom, and they can also help in various forms of impulsivity. ACRM drugs, selective estrogen receptor modulator drugs. Endoxifen, although many like to believe it is ACRM, at the dose we use it is not ACRM. It is more only kinase inhibitor. But tamoxifen 40 plus mg dose is ACRM. So is raloxifene and other drugs. They provide us a unique estrogenic avenue, which gives the female brain specifically a good stability, works as cognition enhancer, works as various forms of mood elevator. What we don't know is the dose, and what we don't know is the long term effect of the dose. So, at this moment, they can be used as a rescue drug more rather than a chronic long term use drug for various cognitive and divisive symptoms of psychosis. Monoclonal antibody cocktail. We all know monoclonal antibody cocktail of various cancers, various autoimmune diseases. In psychosis too, they can be applied. Interleukin 6 inhibitor along with interleukin 17 inhibitor along with interleukin 2 inhibitor along with interleukin 8 inhibitor from very early age is a good cocktail. Main problem is the cost. Someday soon, when the cost gets remitted, this would be one of our first choice for preventing neuroprogression. There are various trials all over the world of their use in schizophrenia, within inverted comma. But most of the trials are on single monoclonal antibody, and most of the trials are on burnt out case. That is why they are not expected to get good result. Antibiotics. Already, most of you know linezolid from some of my other lecture. Linezolid is an antidepressant. Many of you know about minocycline. Minocycline is an antidepressant. Many of you know about tetracycline and doxycycline. They are also a complicated form of antidepressant as well as kind of drugs which reduces extreme brain activation. But almost all drugs in the antibiotic area works on brain and works on different areas of brain. The trick is to find out which area they are useful and how much dose they are useful. Penicillin group of drugs are mostly antipsychotic, mostly drugs which reduces aggression and things like that. Ofloxacin group of drug or fluoroquinolone, they are on the other hand slightly on the area of a brain activator and brain stimulator. But we need more data before we want to use them. And the biggest problem of theirs is they are various gastrointestinal side effects and other side effects. But we might hope that based on their working principle and molecular structure, a new group of psychotropic drug can emerge from them. Purinergic drugs. There are various purinergic drugs. Many of you have heard only about allopurinol. Now, allopurinol is a drug that causes severe suppression of brain excitation and can be used in refractory positive symptom, refractory mania, and various other drugs. ঠিক আছে, কোথায় যাচ্ছেন? ঠিক আছে, ঘুরতে। ঠিক আছে, ওকে। নাও purinergic drugs can be blocker, can be purinergic stimulant. Many purinergic stimulants can very well be used to enhance attention and concentration, and many are already being used as drug which can enhance attention and concentration of chronic psychosis patient. Tea and coffee, they have purinergic agonists as their main working principle, and that is why many a time patients self-medicate them with tea and coffee. Clopidogrel is a purinergic antagonist, and similarly ticlopidine and clopidogrel, they are purinergic antagonist. In right dose, they can also use in positive symptom, in aggression symptom, and things like that. Now, centrally acting sympathetic blocker, alpha methyl dopa, clonidine, dexmedetomidine, and all these three have good action in aggression, in various form of hyperactivation, various form of impulsive behavior, and we can very easily use them in mania. If anyone wants to read literature, they can give a search of clonidine and mania. They would find out that clonidine used to be a good mainstream antimanic agent before all these pharmacological lobby became active. Peripheral sympathetic blocker, trazodone, has a good effect on reducing aggression, as well as tirazosin, as well as all the alpha 1 blocker. Anti-allergic medication. Amongst anti-allergic medication, most of them have sedative property, have properties to reduce brain activation, and properties to reduce impulsive behavior in adequate dose. Calcium channel blockers. They are useful in aggression. They are useful in various form of impulsive and compulsive behavior. They are useful in various form of excitotoxicity, be it nimodipine, be it amlodipine, all are useful. Verapamil, DPP4 inhibitor, sitagliptin, vildagliptin, they are drugs that increases brain's activation of insulin like growth factor 1 And being a facilitator of that pathway, they increases brain cell function, they reduces the cellular strain, and they ultimately have efficacy in reducing dysphoria, have efficacy in reducing anhedonia, and ultimately, in combination with various drugs, they have prominent cognitive effects. Biguanide, unsurprisingly, metformin is one drug that increases cognition and that increases the cellular control of excitation and that ultimately prolongs cellular longevity. SGLT2 inhibitor, dapagliflozin, empagliflozin, all of them has their brain effects, and that brain effect leads to increase in brain's utilization of glucose and enhancement of brain action. GLP-1 agonists, the most blamed drug, Ribelsas, Ozempic, and how people love to blame them for doing this on brain, doing that on brain. They don't have any adverse benefit. Rather, if anyone is interested, they can go and find meta-analyses on GLP agonists, specifically liraglutide, and its various brain protective activity. It has been proposed as one of the most
Bhaskar, you are not heard. There's an audio problem from your end.
Possibly from like a lacking of network.
I think because he's not even visible.
Let me talk to him on the phone. You're not audible for the last 5 minutes. I just have talked to him.
Possibly they can rejoin the session.
I'll ask him. Hello? rejoin the session. Yeah. It'll come now.
So let's start again from where I missed.
The last slide that you spoke up was
Liraglutide, right? Thank you, ma'am. I was talking about liraglutide. Liraglutide. Am I audible now?
Yes, sir,
Am I?
perfectly.
you're audible.
Okay. As I was talking about, liraglutide has various brain activation properties and brain protection properties. If anyone is interested, they can have a look in Google Scholar. Now, after GLP-1, it is dual GLP-1 and GIP agonist, tirzepatide. Tirzepatide, or being stronger than GLP-1 agonist, also have various neuroprotective, neuroenhancing role as well as cognitive, being a good cognitive enhancer. Unfortunately, data is not much there yet. It is a very new drug, very new approval, and all these things that are being told about neuroprotective action of tirzepatide is actually just scientific understanding from liraglutide. Various antiviral drugs, lamivudine, zidovudine, they are pro-depressant and they reduces excitation, ultimately leading to better control of impulsivity. All protease inhibitors work closely similarly than kinase inhibitors. Various anti-cancer drugs, already endoxifen and tamoxifen has been repurposed. Various other anti-cancer drugs are slowly being repurposed to psychiatry because the thing is, people have started understanding the basic molecular development of psychiatric symptoms and cancer is similar. So the bullet points. People always ask me bullet point. We have to understand that we are spoiled for choice. There is no single base drug. There are thousands and thousands of drugs. We have whole pharmacopoeia at our disposal. Any drug that works on one non-communicable disease would work on others. We just need to know how and why. All non-communicable diseases are branches and non-communicable diseases of brains constitute the stem and backbone of non-communicable tree of diseases. There is no treatment resistance in any non-communicable disease, either ignoring the body or brain if treatment resistance appear. Let's say treatment refractory hypertension. The cardiologist is missing the brain component. If we start these patients on antidepressant, most of them would start responding. Treatment refractory hypertension is one of the glorious example of missing brain and treating body, leading to a lot of problems. Similarly, if a person has various kinds of viral disease, let's say a patient is on HIV polytherapy or antiretroviral therapy, this patient is already having a strong reducing element on brain sexual toxicity. So if we don't notice that and give usual dose of antidepressant in this patient, that would not work. কোথায় যাচ্ছেন? So we have to understand these finer points. And with this, I now stop this lengthy, boring lecture.
Thank you, Bhaskar, for that exhaustive coverage of the understanding of what can go wrong, what systems are involved, and what can be done to modulate the systems as best as we can with the kind of medications that we have at our disposal, not necessarily limited to the conventional psychotropics that we are so fond of. So, we have got some questions. We'll take them now. Yeah. So, am I audible?
Yes, you are audible.
Yeah. So, the first question is from Dr. Divay Mangala, and he has also asked a couple of other questions. So, we'll take them one by one. The first question that he asks is, will treatment change pregnancy outcome as we are treating only symptoms but not the genetics? Yeah, Bhaskar.
Disconnected, is coming back again.
Okay. Yeah,
Sorry.
Yeah. So the question is from Dr. Divya Mangla, will treatment change pregnancy outcome as we are treating only symptoms but not the genetics?
Will treatment change pregnancy outcome? Depending on what outcome we are seeing. If we are saying pregnancy outcome in form of eclampsia, preeclampsia, then there is a sure chance of reducing that. If by pregnancy change we are meaning that maternal various kind of diseases, then there is a chance of that getting stopped. Regarding neurodevelopmental profile of fetus, we are not in a stage to answer with a simple yes and no because we don't have enough data.
Okay. Another question is, will low dose antipsychotics help in epilepsy?
Low dose antipsychotics would help in epilepsy only and only if there is evidence that the cellular excitation is also problematic along with cellular transmission. And if we add, many a time we add first generation antipsychotic or second generation antipsychotic to epilepsy, considering it is that epileptic encephalopathy has happened, and there we get benefit. Nobody has looked for the advantage, so there is no data. But with use of antipsychotic as a treatment for epileptic encephalopathy, so far no worsening has been seen. Does that constitute a proof? No, it doesn't constitute a proof. We don't have any direct proof.
Okay. Dr. Ritvik Chatterjee has asked a question. What are antidepressant activating symptoms and when do we suspect it? I think during the presentation you
Hmm.
mentioned some of this, but can you just tell
Yes,
us quickly?
antidepressant activation syndrome means the patient is getting less sleep, patient is getting restless, patient is becoming uh, actually having higher heart rate, respiratory rate has increased, and various other things has happened.
Okay. Uh, Dr. Amrit Bodhani asked a couple of questions. First question is, what molecules would you suggest for deliberate self-harming behaviors like wrist cutting?
Obviously, naltrexone is so far the best option. Along with that, we can use cannabidiol. It seems promising because it works in similar areas. Along with that, lithium also is an option. If we extend our understanding by then drugs that would reduce the motivational circuit hyperactivity without hampering the prefrontal cortex or cerebellum activity, then low dose antipsychotic should also work, as well as various anti-epileptics would also work.
Okay. The other question that he asks is, can we consider galantamine for cognitive impairment in schizophrenia? I think that
Yes,
is
I
pretty
have
much,
talked
yeah.
about it,
Okay.
and it only has evidence, slight
Okay.
evidence, but it only has evidence.
Okay. Um, yeah. Yeah. Dr. Vishal Sinha asks, how does this bupropion dextromethorphan combination work, and in which group of patients would you? Uh,
Bupropion dextromethorphan combination I have not written personally, so I would not be able to tell from my personal experience. What I would say is by scientific logic. This is the caveat. Now, dextromethorphan is a NMDA receptor modulator, so it should work in brain excitation and it should give brain some form of, I would say, increased cognitive effect. Along with that, if we add bupropion, then the cognitive effect should increase. Along with that, we should also have increased attention. The problem of this combination would be if there is underlying excitotoxicity in form of hidden epileptic vulnerability, that would be triggered more, because both are ultimately increasing excitatory transmission. But this opinion should not be trusted before we actually are able to use this drug.
Dr. Sunny Dua asks a question, can we use amantadine and cephinamide in tardive dyskinesia?
Yes, in tardive dyskinesia, both of them are very useful. I have personally used both. Most people use only amantadine. Many people have not used safinamide here.
Okay. Uh, Dr. Paresha asks, can allopurinol cause depression?
Obviously, this is a drug that is going to cause depression.
Yes. Dr. Mukesh Batra asks, what about L-methylfolate? How would you place L-methylfolate with respect to what we have discussed today?
L-methyl folate is a nutraceutical, and Being nutraceutical, this low dose has no value. If only there is methyl tetrahydrofolate reductase
Efficiency.
enzyme mutation, and along with that, that enzyme has a low functioning variant, then L-methyl folate works. Otherwise, there is no point in giving it.
Okay. Dr. Gaurav Rajendra asks, how long do we need to continue the options that you have talked about? For example, metformin or allopurinol.
Allopurinol, being a prodepressant drug, should be given 3 to 6 months, not more than that. I have tried mega doses of allopurinol in patients and I have found them getting depressed very well. So allopurinol should not be given long term. For metformin, lifelong is good enough.
Uh, so in addition to the question that, I mean, in addition to what he just asked, the second question is the effect that you see with these agents, are these effects consistent or they wane off over time?
Which agents?
This one, his continuation of the same question, metformin, allopurinol.
Metformin, if you are seeing the effect, we don't see the effect easily in many of these drugs because as I started with the saying that pharmacological non-psychotropic treatment has the disadvantage of being non-standardized. So we don't know how much dose is needed in each person. But if a person responds to them, then the response continues.
Right.
For example, I have seen a borderline patient of mine got well with liraglutide, very good. Her recurrent depression is gone, and her various mood symptoms are much stable. That effect was there till liraglutide was continued, and it was continued for 5 years. For 5 years, she was better with liraglutide.
Okay. Last two questions by Dr. D.Y. Mangala again. Uh, how do you explain symptoms of narcissistic behavior based on what we have tried to understand
Uh,
today? If you want to take it now, or we'll keep it for later.
Narcissistic behavior, I don't understand
Okay.
because the thing is, narcissistic behavior has no brain, which actually counterpart. There is no narcissistic person who has entered a functional neuroimaging, sat there, has done various work, and there are at least a few thousand persons who has done this, and we have got a brain map of narcissistic personality. There are not a single person who has done. So, what is labeled as narcissistic behavior is something that is known only by the psychologists who label them. And last 20 years, I have not trusted any humanities expert. So no, there is no point in saying that. Give me a proof that there is a narcissistic brain pattern. Give me a proof that it is reproducible, replicable, and it stays fixed. Then we talk about narcissistic personality, not before that.
Okay. The last question is, what are the clinical indicators that there is some mitochondrial pathology going on? How do you pick it up in routine clinical practice?
The best way is to check serum ammonia, check serum lactic acid, check serum CPK, and check serum ammonia. If they are not within normal range consistently, only one instance should not be judged. at least do a serial testing. If the serial testing is happening well, above the normal range, then we are dealing with a mitochondrial disorder.
No, but when do we suspect? Do we do it in all patients? Do we do it in some
We
particular kind of
we
presentations?
ideally we should do it in patient any patients who present to us with epilepsy, with autism, with attention deficit, with neurodevelopmental various syndrome should be screened with minor physical anomaly scales. Then, if they have high minor physical anomaly, then we should screen these. If they are high, then we have to be clinically suspicious that we are dealing with mitochondrial disorder.
Okay. I think that covers all the questions that have been put up to you, Bhaskar. Once again, thank you so much. And with that, I hand over the proceedings to Dr. Rajkumar sir.
Thank you very much, Dr. Malay. And thank you, Bhaskarda. It was wonderful. And I hope all of us have enjoyed it. End of the day, thank you very much. We'll be meeting again after a fortnight. With that,
And that would be case discussion
yeah,
where I and MD would be the moderators and juniors would present. And this that would conclude this session of it's bipolar as well as schizophrenia.
yeah, that should be there. Thank you. I also thank the Alchem CNS division for being the knowledge partners. And good night to all of you. Good night, Bhaskarda, as well
Good
as
night.
Malay.
Good night.
And we need to have a Brain on Wednesday YouTube channel that has all the lectures.
Yeah, there is a
Skills
YouTube
lectures.
channel. Yeah.
Yes, we have the YouTube channel, but all the lectures are not uploaded.
Last
It will,
three are
it
not
will,
there.
I will be taking that up with him.
Yeah.
Hmm.
Okay.
Okay.
Good night.
Good night to all of you.
Bye.